The meeting is, as of now, being recorded. Good morning, everybody, and welcome to Grand Rounds. It's February 14th, an excellent day to celebrate love in its many manifestations, including this one, where we join together in our collective passion for medical education. I will begin with the land acknowledgement. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. Now it is my pleasure to present the presenters, four, not one, not two, not three, but four of the shining stars in the constellation that make up our pediatrics residency program. We have Kristine de Jesus, Stephanie Dobson, Sana Gill, and Janaya Perron. I'll give you their biography briefly. Kristine, Stephanie, Sana, and Janaya are PGY3 pediatric residents with an interest in teaching and education. They enjoy working with children and learning through the various styles and methods in their training. And that is not a biography I wrote for them. This is what was provided to me, but I will definitely be quoting this during our accreditation survey. The presentation that they're giving today, as you can see on the screen, is the Febrile Newborn and a review on what to do. So without further ado, I'll let you take it away.
Thanks, Dr. Herman. So I'm Janaya. I'm one of the third-year residents, and then joined with me today is Sana, Stephanie, and Kristine. Our presentation today has been supervised by Dr. Kara Sepper. And as Dr. Herman mentioned, we're going to look at fevers in the little babies and a review on what to do. Our learning objectives for this presentation is to get an understanding of the epidemiology of fevers in newborns, discuss the clinical approach to a newborn with a fever, review the current clinical practice guidelines, and then look at a couple of cases and apply our recommendations to those cases. So our presentation will start with some cases, and then we'll get some background on fevers in neonates and young infants. We'll have a look at the clinical approach, look at different investigations and their utility, look at different risk stratification tools, look at the guidelines from the CPS and from the AAP, and then look back at our clinical cases. So welcome to your ED shift. You're at CHEO Emergency Department. It's busy, and you're just starting out your day. It's 8 o'clock. It's Tuesday morning. You're just starting the day shift, and the triage nurse comes over to you and your two colleagues and says, there are 3 young patients who have just arrived, and they've all been roomed, and they all have a fever, and their CTAS is 2, but they look good, but they'd like you to see them as soon as possible. So you take a look at the triage board, and you decide to divide the 3 patients between the 3 of you. So today you have Jack, Lucy, and Max, who are 17 days old, 10 days old, and 37 days old, and all you know about them is that they have a fever. So you head into room 1 to see Jack, and this is Jack, our little 17-day-old male, term baby, otherwise well, uncomplicated pregnancy and delivery, GBS negative, no HSV risk factors. He presents with the history of a 2-year-old sister that had some URTI symptoms. She attends daycare. Mom wondered if he maybe had some symptoms as well, so took a temperature at home and was found to have a rectal temperature of 38.3. Otherwise, he's been well, and when you examine him, his vitals are all within normal limits with the exception of an elevated temperature at 38.4 rectal. His exam is normal, and you don't find any focus of infection. Your colleague heads to the next room and sees baby Lucy. Lucy's 10 days old. She is also a term baby. Mom was GBS positive, and she wasn't sure if she received intrapartum antibiotics, but otherwise had routine antenatal care with no concerns regarding pregnancy or delivery, no HSV risk factors. Again, Lucy's healthy as well. Lucy's history is that mom thought she felt a bit warm, and so they checked her temperature, and her rectal temperature was 38.4. Similarly, she's otherwise been well, and her exam is normal with the exception of a fever. And your third colleague goes to see baby Max, who's our 37-day-old male, again, term, otherwise uncomplicated pregnancy and delivery, healthy baby otherwise. And his story is that he was a little bit fussier today, so dad decided to check his temperature, and it was 38.2. Otherwise, he's been feeding well and doing well with no other symptoms. And on your examination, his vital signs are within normal limits. His temperature in the emergency department is 37.7 rectal, and otherwise he has a normal physical exam. So you essentially have these three patients who have very similar stories in terms of being sort of in a young age between that sort of neonatal and young infant group, otherwise relatively uncomplicated pregnancies and deliveries, and then a tweak in their story in terms of some viral symptoms, a tactile temperature, and then just a bit of fussiness, but otherwise well-appearing children. So what will you do next? Now that you've taken your history and you've examined your patient, you start thinking about what investigations you need to do and what management you need to employ. You also happen to be working with a medical student today who's very keen and asks why fevers are so important in the young infants, and they ask you to tell them about all the guidelines that exist so that they can learn. So at this point, we'll get you to think about what your next steps might be, and we'll give you a bit of background and help you sort of formulate those steps. So for the purpose of this presentation, just some definitions. Fever is among infants aged less than 90 days is any rectal temperature that's greater than 38.0 degrees, measured at home or in a clinical setting. Serious bacterial infections will include UTIs, bacteremia, and bacterial meningitis, and invasive bacterial infections include bacteremia and bacterial meningitis. So fevers in neonates and young infants, a bit of background. Fever is a really common symptom that you'll see in neonates and infants aged 7 to 90 days. It's a common reason for presentation. Overall occurrence of fever is 2.2%, including 1.4 who were subsequently confirmed to be febrile in a medical setting. About 10% of febrile infants less than 3 months will have a serious bacterial infection. So that's your UTI, your bacteremia or bacterial meningitis. The prevalence of invasive bacterial infections, specifically bacteremia and bacterial meningitis, is the greatest in the first month post-birth and decreases with age. There's quite a considerable variation in the approach to infants presenting to the ED or outpatient clinics with a fever. And part of your treatment and management is to sort of weigh the risks and benefits of treating and investigating versus the risks of infection as well. And there's been no single management strategy that's been absolutely universally adopted between countries, which has led to some variations between care in Canada and care in other countries as well. Looking at this article that was published in Pediatrics on the management and outcomes of previously healthy full-term febrile infants in this age group. This was a study done in Northern California. It was a retrospective study that looked at febrile infants that were term healthy babies that had presented with a fever. They looked at 1,300 infants that had come into a medical setting with a fever, and the incident rate was 14.4 out of 1,000 full-term infants at their center. Out of these 1,300 patients, 195, which was 14%, actually had an infection. The vast majority, which was 183 infants, had a UTI. 36, which is about 2%, had a bacteremia, and 4 patients, which was 0.3%, had meningitis. Infections were identified in 18% of infants in that neonatal period up to 28 days, and then 13.9% up to 60 days, between 29 and 60 days, and then 10.8% between 61 and 90 days. A full evaluation, which included urine, blood, and CSF culture, occurred in 59% of infants up to 28 days, 25% in 29 to 60 days, and 5% between 61 and 90 days. And this is just a graph that sort of represents similar information there in terms of what their workup looked like. The purple bar is the full evaluation with blood, CSF, and urine cultures, which, as you can see, the highest proportion at 59% here was that neonatal period. And then no culture, which is the blue bar, had the highest proportion in the older group, which was 61 to 90 days. And the reasons in this study for no cultures being obtained in these groups in the neonatal period up to 28 days, it was because they didn't believe the thermometer or there was environmental conditions, which was 63% of that population. And then in the older groups between 29 and 90 days, they had concurrent upper respiratory tract symptoms and felt that was the reason for their fever.
All right, thanks, Janaya. So moving on, so just briefly touching on history, what are some of the things that you might ask for? Initially, you just want to gauge if the child is well appearing, well or unwell. So change in behaviors from baseline would give you a good understanding of that. So if there's any lethargy, irritability, inconsolability, that may show that the child actually is appearing unwell. And then the risk stratification strategies that we'll be talking about may not be applied in that case. You also want to ask about the fever history, so number of days they'd had fever, and any associated symptoms that may point to a focal source of infection. And in this age group, as you're already aware, one of the main things that you want to really screen for is birth and neonatal history, particularly looking for early sepsis, early onset sepsis risk factors, which include intrapartum GBS bacteria during pregnancy, any prolonged rupture of membranes, maternal fever, or maternal HSV history. And then immunization history is important. In particular, in infants, they can have post-immunization fever. If this fever is happening within the first 24 hours, that is associated with low risk of serious bacterial infections. But if this fever is persisting beyond the 24-hour period, in that case, you will want to investigate further with potentially like a urinalysis, for example. You also want to look for sick context on history and any recent travel. And there are also commonly accepted risk factors which may pose an infant to be at increased risk of serious or invasive bacterial infection. A lot of the research that's done on infants actually exclude infants with these accepted risk factors. And therefore, the risk stratification tools that we'll be talking about are not applicable to these infants with these risk factors. And these infants should actually be worked up based on an individualized and conservative approach. So these risk factors include history of prematurity, prior hospitalization, or prolonged NICU stay, if they have any chronic medical conditions, genetic abnormalities, technological dependence, if they have known or suspected immunodeficiency, recent antibiotic exposure, or any focal bacterial infection as well. So on physical exam, you always want to start by getting full set of vitals. In infants, as Janaya was saying, fever is defined as rectal temperature of 38 or more. In infants, oral, tympanic, axillary temperatures are not good indicators of core body temperature. So it should be ideally rectal mode of checking temperature. And then in this age group, hypothermia, so rectal temp of less than 36 is equally as concerning as fever and should be investigated. In terms of height of fever, there has been conflicting evidence. Studies have shown that even though height of fever may indicate a serious bacterial infection, however, that factor alone should not be used as a measure of risk stratification in infants, because there is a large proportion of infants who may actually have fever of maybe 35.5 or less, who may still have a serious or invasive bacterial infection. On your physical exam, you also want to look for any concerning signs, so altered LOC, inconsolability, bulging fontanelles, petechial rash, or any other signs that may show a focal infection such as AOM, pneumonia, septic arthritis, things like that. In terms of investigations, so Steph and Kristine will talk more about which investigations to order and when. This is just a brief overview. So for investigations, you would consider CBC with differential, urinalysis, and urine culture. And as we are already aware, UA with positive leukocytes, nitrites, pyuria would be suggestive of UTI. If there are any respiratory symptoms, you could consider a viral swab. And if there is respiratory distress that's beyond a bronchiolitis picture, you could consider a chest X-ray as well. And then CRP and procalcitonin, studies have shown that these biomarkers actually outperform ANC and white blood cell count as markers of invasive bacterial infection. So just briefly, a C-reactive protein, or CRP, is an acute phase protein that's synthesized in the liver. It's produced under IL-6 stimulation in inflammatory conditions. And procalcitonin is a prohormone for calcitonin. It's secreted in the thyroid gland for hormonal stimulation, but also by a lot of the other body tissue in pro-inflammatory states as well. So CRP benefits are, it's much cheaper to test than procalcitonin. However, it takes longer to rise, so 12 to 24 hours to rise, and then it remains elevated for 3 to 7 days. Whereas procalcitonin actually has a faster rise. So it rises in 2 to 4 hours post-inflammatory state, and it tends to peak around 8 to 24 hours. It has a half-life of about 24 hours, so it tends to normalize quickly with recovery. And therefore, research has shown that procalcitonin actually is the most sensitive and specific marker for invasive bacterial infections. So there was a study that was published in 2016. It was a prospective cohort study that assessed infants between ages of 7 and 90 days of age who presented to 15 emerge departments in France with fever. And it looked at the diagnostic performance of different biomarkers, including CRP, procalcitonin. And as you can see here, these are the graphs which show sensitivity of these tests. And on the right, you can see that procalcitonin is actually more sensitive compared to even CRP in detecting invasive bacterial infections. And this is a statistically significant difference. And on the left, you can see that comparing CRP and procalcitonin, they kind of perform similarly in terms of detecting serious bacterial infections. And as Janaya had said earlier, similar to our presentation, invasive bacterial infections were defined as bacteremia or bacterial meningitis, whereas serious bacterial infection is positive urine culture, blood culture, stool culture. So overall, this study showed that procalcitonin is superior as a diagnostic test in accurately identifying invasive bacterial infections compared to CRP. But in serious bacterial infection, both CRP and procalcitonin perform equally well. And then moving forward, if there are any concerning neurological signs, or as we'll talk about later on for risk stratification strategies, recommendations, you may pursue lumbar puncture. And in the CSF, you will look for cell count, glucose, protein, and culture. And of note, CSF cell count is actually more accurate than glucose or protein for predicting bacterial meningitis. And as you may already be aware, CSF plus cytosis is more than 15 cells for infants less than 28 days and more than 9 for infants more than 28 days. And then in 20 to 60% of attempts for lumbar punctures, you may actually have a traumatic lumbar puncture. And that may actually lead to like prolonged hospitalization or repeat of an invasive procedure. So to avoid that, you could do a ratio-based correction method of 1 white blood cell count for every 877 red blood cell counts. This is a brief summary of interpretation of CSF, and you guys are, most of you guys are probably already aware of this. But in bacterial meningitis, you would see elevated protein, low CSF to serum glucose, and neutrophil predominance, whereas in viral, you would see lymphocyte predominance, normal protein, and usually normal CSF to serum glucose ratio, whereas in fungal and TB infections, you might see lymphocytic predominance, elevated protein, and actually low CSF to serum glucose. In terms of HSV, again, as you're already aware, it could be skin, eye, or mouth disease, or it could be disseminated or CNS disease as well. So a study, the largest study actually to date of infants less than 60 days of age who were presented to emerge for meningitis assessment had kind of studied this population and came up with this HSV risk score guideline. As you can see in that table, lower age, seizure at home, ill appearance, vesicular rash, thrombocytopenia, or prematurity are risk factors for invasive HSV disease. So as per this study, a score of less than 3 is actually correlated with low risk of CNS or disseminated HSV. But of note, it is important to note that sometimes infant would only present with fever as their only sign and may still actually have a serious HSV infection.
Okay, so given the high morbidity and mortality of invasive bacterial infections in young infants, guidelines in the 1970s to 1980s recommended a full septic workup in all infants less than 3 months of age. However, we know that many infants will have an environmental temperature, a viral illness, or a UTI, and this has led to wide clinical variability on how institutions approach and manage young infants, as Janaya discussed earlier. As such, low-risk prediction models were developed. The original prediction models developed in the 1980s to 2000s included the Rochester criteria, the Boston and Philadelphia criteria. These prediction models were developed to identify patients with low risk of serious bacterial infections in well-appearing children with temperatures of at least 38 to 38.2 degrees Celsius. They excluded patients with other medical conditions, focal sources of infection, and or prematurity. All 3 criteria looked at white blood cell counts and urinalysis, whereas the Rochester and Philadelphia criteria also looked at band counts or ratio. In addition, the Boston and Philadelphia criteria also required the infants to have lumbar punctures to risk stratify them as high versus low risk. The only criteria to look at patients less than 28 days of age was the Rochester criteria, which is the most common one that was being used. These models had high sensitivities and high negative predictive values. However, we've learned a lot since then. For example, as Senna shared, we know that CRP and procalcitonin outperform some of the originally used laboratory values. We also know that the laboratory test parameters that were used in the original studies were based on expert-driven cutoffs and were not statistically derived. There's also been a change in the epidemiology and prevalence of serious bacterial infections through many factors, including improved GBS screening, intrapartum GBS prophylaxis, food safety, and vaccination. The most common form of bacteremia is now E. coli. GBS remains our main source of meningitis, and we have very low incidence of listeria now. So the question really is, can we develop evidence-based models to help further reduce our antibiotic exposures, LPs, and hospitalizations in infants less than 3 months of age? The first new model to be published was the step-by-step approach, and this was published in 2014. This was a retrospective multi-center study from the European collaborative approach and was completed in 7 emergency departments, 5 in Spain and 2 in Italy. It included 1,123 infants less than 3 months of age, including 7 patients that were diagnosed with meningitis. Patients were excluded from the study based on fever uncertainty, so only having a tactile fever at home and then no fever measured in the emergency department. Infants having a clear fever source, having certain diarrhea or respiratory symptoms, or if there were missing investigations. So to use this approach, you first determine if the infant is well appearing or not. If they are, you then look at their age. If they're greater than 21 days, they're automatically determined to be high risk in this approach. But if they're less than 21 days less than 120 days is high risk. But if they were greater than 21 days, you would then look at their urinalysis. If their urinalysis is negative, you then look at their blood biomarkers, specifically looking at their procalcitonin, CRP, and ANC. If the procalcitonin is less than 0.5, the CRP is less than 20, and the ANC is less than 10,000, those patients would be classified as low risk. Interestingly, in this study, only the procalcitonin was an independent risk factor for invasive bacterial infections alone, with an odds ratio of 21.69. So using this approach, only 1 patient in the low-risk group did have an invasive bacterial infection. This was externally validated in a prospective study of 2,185 infants in 11 European pediatric emergency departments, and this cohort included 10 patients with meningitis. It did misclassify 7 patients, and interestingly, the fever duration in 6 out of 7 of those patients was less than 2 hours from fever presentation. And as Senna described, there is a time dependency of our inflammatory markers. So this is a very interesting finding. The sensitivity for invasive bacterial infections was 92%, and for the negative predictive value was 99.3%. A second prediction rule was published in 2019 by the PCARN Research Network. This was a prospective observational study completed in 26 emergency departments in the States. And in this study, they included a derivation cohort of 908 infants and a validation cohort of 913. And this included 16 patients with meningitis. They too excluded infants that were critically ill, that had received antibiotics in the preceding 48 hours, had a history of prematurity, pre-existing medical conditions, indwelling devices, or soft tissue infections, but they did include patients with AOMs and respiratory symptoms. The study looked at 9 possible predictors of invasive bacterial infections using univariable analysis, including age, qualifying temperature, duration of fever, the Yale observation score, a score to help distinguish well versus unwell infants, unstructured clinical suspicion, white blood cell count, ANC count, urinalysis, and procalcitonin to identify predictors who were significantly associated with an IBI. They then went on to use binary partitioning analysis to derive a prediction rule and determine the optimal value cutoffs. And this identified 3 predictors, which makes up the PCARN rule. And that includes a normal urinalysis, an absolute neutrophil count of less than or equal to 4,090 cells per microliter, a serum procalcitonin of less than or equal to 1.71. The sensitivity for this prediction rule was 97.7% for serious bacterial infections and 96.7% for invasive bacterial infections, with a specificity of 60%. Interestingly, application of this rule to their cohort could have saved 523 lumbar punctures, so a lumbar puncture in roughly 1/3 of the infants included in the study. External validation was completed via a secondary analysis of a prospective registry in a tertiary hospital in Spain. So caution that this was just a single center study, and included 1,247 patients. The sensitivity in this external validation was, however, lower. So it was only 89.8% for serious bacterial infections compared to 97.7%, with specificity of about 55.5%. Interestingly, they also looked at the sensitivity in children that were presenting with a fever of less than 6 hours, so similar to the prior study, and did show that it was slightly less sensitive, but this was not statistically significant. The third score is the Aronson score, and this is the most recently published, also in 2019, and was developed by the Febrile Young Infant Collective using a case control study of infants in 11 different hospitals during a 5-year study period. It included 181 infants with invasive bacterial infections, including 155 with bacteremia and 26 patients with meningitis, which is the largest number of any patients with meningitis in any of these studies. It looked at multiple different predictors, including past medical history, including gestational age, historical features such as household sick contacts, symptoms of a URI or duration of fever, measured temperature, physical exam findings, and vitals at triage, as well as labs including white blood cell count, ANC, CRP, procalcitonin, urinalysis, and culture results. They then used weighted logistic regression to identify a score. And so using this, they identified that the 5 different points that they gave weighted based scores. The first being age less than 21 days, which got 1 point. The highest temperature in the emerge of 38 to 38.4, which got 2 points, or a temperature of greater than or equal to 38.5, which got 4 points. An absolute neutrophil count of greater than or equal to 5,185 cells per microliter, which got 2 points, and an abnormal urinalysis, which got 3 points. This study did not use procalcitonin in their final weighted score because the authors really wanted this to be a rule that could be generalized to more hospitals. And as we know, not all hospitals have the capability of running a procalcitonin at this time. So they found that using the points of less than or equal to 1, or a score of greater than or equal, their score of greater than or equal to 2, gave a sensitivity of 98.8% and a specificity of 31.3%, and correctly classified all patients with meningitis. This was externally validated in a prospective cohort of 4,130 patients at 26 PCARN emergency departments and showed good generalizability. It did, however, miss 3 bacterial meningitis patients in the external validation cohort. And these patients, 2 out of the 3 were less than 28 days of age, really highlighting again that the first month of age is our highest risk group for invasive bacterial infections. So comparing all 3 of the new rules, so both the PCARN and the step-by-step approach use procalcitonin and require that all their criteria be negative to be considered low risk. In comparison, the Aronson score does not use a procalcitonin and uses a weighted-based approach. The step-by-step score is the only score that will consider patients high risk based on age alone, so less than 21 days. It also excluded patients with respiratory symptoms. The Aronson score, age is also used as a criteria, and if the patient was less than 21 days of age and had a fever of greater than 38 in the emergency department, they too would automatically be considered a high-risk patient. So as Senna reviewed earlier, based on the exclusion criteria that were used to derive these prediction models, they haven't been validated in patients with a history of prematurity, prior hospitalizations, or like a long NICU course, chronic medical conditions, suspected or known immune deficiencies, recent antibiotic exposures, or any focal sources of bacterial infection with the exception of AOMs. So therefore, you need to have extreme caution if applying to these patients.
Okay, so as you guys can see that based on the fact that there hasn't been a united approach to how to manage these kids in this young period, and given the advent of these new stratification tools that Steph went over, 2 major papers have been released, one by the American Academy of Pediatrics, which was published in August of 2021, and the second one being the Canadian Pediatric Society, which was published in October of 2023. And both these papers are trying to provide a current evidence-based approach to fevers in this age group, so under 60 and 90 days of age, particularly highlighting use of the inflammatory markers to try and identify those infants at highest risk of invasive bacterial infection, specifically being, again, the bacteremia and the bacterial meningitis. So I'll spend the next few moments just going through each of these guidelines. No, there we go. Okay, so the first one I'll go over is the CPS guidelines, the Canadian Pediatric Society. And so what they do first, they divide their kiddos into 3 major age groups. The first one being in the 0 to 28 day. And so the first part of the algorithm is essentially doing what we generally do, is to decide whether or not these kids are well or not well. And this is based on the pediatric assessment triangle. If any kid is considered to be not well, they're automatically excluded from this algorithm. The next step is to look at if these kids have any risk factors. So the risk factors that we've already gone over, that being if they're premature, so less than 37 weeks, prior hospitalizations, if there's any previous chronic medical conditions, genetic conditions, suspicions for metabolic conditions, if there's been any recent antibiotic use or any focus of infection, then they are also automatically excluded from the algorithm. And then the next step is to do the initial investigations. So for the CPS guideline, they recommend that in this age group, all kids receive a CBC, the inflammatory markers. So again, CRP and procalcitonin. You do the blood culture, the UA, and the urine culture. And again, based on your clinical suspicion, you can or cannot do a chest X-ray as well as viral panel. Based on the initial investigations, then we apply the prediction tools that Steph went over. So either the PCARN, the step-by-step, or the Aronson rule. Based on that, you will decide if these kids are either high risk or low risk. I just wanted to highlight again, as Steph did, is that in this age group, so from the 0 to 28 days, based on 2 of these prediction models, age alone would be enough to consider these kids high risk. So this would be the decision tree, so low risk versus high risk. I'll start off at the high risk group because this is more straightforward, more consistent to what we've been previously doing, and that these kids are high risk for invasive bacterial infection. So an LP would be warranted, sending for the CSF, protein, glucose, starting empiric antibiotics, which I'll touch on in a little bit, and then admitting these kids to hospital and observing them for 36 hours, awaiting for the cultures to come back. The low risk for invasive bacterial infection in this age group of under 28 days, this is where the practice has changed. And so what they suggest is that not all kids in this age group necessarily require an LP. An LP can be performed, but it would be, you consider the shared decision making, the practical considerations of, can you observe this kid? Is a hospital able to accommodate, watch these sorts of kids, and clinician comfort as well. And so what they suggest is that if you go down the option 1, you can defer the LP. And if you were to defer the LP, then you would hospitalize these kids without empiric antibiotics. The next option would be to perform the LP, and then based on the LP, you would risk them as high risk for meningitis. So in this age group, a pleocytosis of greater than 15 cells, and treat them empirically for meningitis. Or if there's no pleocytosis, so under 15, then you would hospitalize these kids again with or without antibiotics. In all infants in this age group, so regardless if they're low risk, high risk, you would observe all these kids in the hospital for a period of at least 36 hours. However, they do make a comment that they could be discharged home at 24 hours, presuming all the other cultures are negative, if they did come back with a positive virus other than rhinovirus. The next age group they look at is the 29 to 60 days. So again, you would go down the initial assessment of well or not well, evidence of risk factors, and then again, presence of risk factors of infant appearing unwell, then it would exclude them from the algorithm. And then it would be, again, the same initial workup being CBC, inflammatory markers, blood and urine, as well as plus or minus chest x-ray or viral panel. And again, you would apply the same prediction tools to decide if they were high risk or low risk. This again is the different decision tree. So again, high risk for invasive bacterial infection is not too dissimilar to what we've already been doing. And that if there is abnormal inflammatory markers, as I hope we've highlighted, this puts them at higher risk for invasive bacterial infection. And so again, the recommendation would be to do the LP and again, admit these kids and observe them for a period of 36 hours. The low risk, again, is where the variation differs a little bit. I do want to highlight what their definition of low risk for invasive bacterial infection. So low risk is low if, again, per the stratification tool that you use, they come out as low risk. But they also consider low risk for invasive bacterial infection if the only thing on your algorithm, your stratification tool, was that they scored positive for urine. So in other words, they consider infants with normal inflammatory markers at low risk for an invasive bacterial infection, even with a positive urinalysis. So a positive urinalysis in itself is no longer considered to be a high risk for invasive bacterial infection. So based on that, if there's a negative urinalysis, you wouldn't necessarily need to start antibiotics. If there's a positive urinalysis, then you would start antibiotics. And the decision to do the LP or not LP, again, would be based on the shared decision-making, the clinician comfort, et cetera. So there isn't a strong recommendation to do one versus the other. However, if you were to do an LP, you would again treat them for bacterial meningitis based on the CSF pleocytosis. So in this age group of 29 to 60, that's considered 9 cells. And then obviously you would treat and admit them to hospital. But if they did have low risk, so normal inflammatory markers, then again, you have the 2 options. Option 1 would be to discharge them home, but you'd need to ensure close follow-up within 24 to 48 hours. And option 2 would be, again, to hospitalize these kids for a period of, they say here, in 24 hours. For either option 1 or 2, you could or could not start antibiotics. Obviously, if it was a positive urinalysis, then you would, but IV versus oral would again depend on the other varying factors. The last group they look at is the 61 to 90 days. So these kids, they need at the minimum at least a urine and a urine culture. You could apply the same algorithm as the kid, similar to the 29 to 60 days. The only difference being because these kids are older, if they do just have an isolated UTI, so normal inflammatory markers, just identifying a UTI, then you wouldn't necessarily, they do not recommend offering the option to admit them rather. They would be safe to be discharged home with treatment as long as follow-up could be arranged again in the next 24 to 48 hours. This is the recommendations for the CPS guidelines in terms of empiric antibiotic coverage. So overall, in the under 28 days of life, empiric antibiotic, the recommendations would be IV ampicillin with an aminoglycoside being either gentamicin or tobramycin. The only difference being in the first week of life versus the 8 to 28 is there's slightly difference in terms of the tobramycin dose. Whereas in the 29 plus days, so 29 to 60 days, the empiric antibiotic choice would be IV ceftriaxone. If meningitis is suspected in the early age, so under 28 days, then you would add cefotax plus or minus the aminoglycoside, whereas empiric meningitic cover in the 29 plus would be addition of vancomycin. And under the 60 days, as Sana talked about, if there was any concerns for HSV, then acyclovir would be added to the treatment. So next is the AAP guideline. And so the first major difference in this guideline compared to the CPS is that they automatically exclude infants in the first week of life. So in the first 0 to 7 days of life, the authors feel that there is sufficient enough difference in terms of the rate, the type of illness, and the risk of early onset bacterial infection that these kids should be excluded from the guideline. What they also really wanted to challenge was the idea that all kids under 28 days of life were at the same high risk of invasive bacterial infection. They are using the similar studies that Steph already highlighted, and now what they're showing here, and on the left is the risk of bacteremia, and the blue bars are infants in 8 to 21 days of life, and you can see that this is the highest risk of invasive bacterial infection. However, this risk does decrease in the following week. So in 22 to 28 days of life, you can see the risk of invasive bacterial infection does decrease and decreases again from the 29 to 56 days of life. So this guideline really tries to tease out that age group a little bit more. So they also have 3 different age groups that they look at, or 3 different algorithms based on the ages rather. The first one being the 8 to 21 days. So again, 7 days are excluded from this guideline. You apply the same kind of initial assessment. So if they're well appearing, if there's no evidence of focus of infection, that would be included in this guideline. They believe that in this early period of life, that there is enough concern for an invasive bacterial infection by age alone that a full septic workup is required. So full septic meaning the urine, the blood culture, as well as the CSF culture. They recommend that, or that they don't strongly recommend that inflammatory markers are necessary in this age group because that would not change your initial approach to how you would investigate these children. However, they do comment that the inflammatory markers can help further down the line in terms of how a clinician manages the ongoing course other than the initial assessment. So the full septic would be performed, you would start empiric treatment, and then you would admit these kids in hospital and follow their cultures for 24 to 36 hours. So again, not a whole lot different from what we were initially doing, except for that caveat of it's under 21 and not to 28. So here is where it becomes a bit different. So here they're looking at the 22 to 28 day old. Again, well appearing with no focus of infection can be, this algorithm can be applied. The initial workup they recommend is the partial septic workup that we like to call, which is the blood culture, CBC, urine, and the inflammatory markers. So here they're cut off for abnormal inflammatory markers. Their preference is, again, to use procalcitonin. So a procalcitonin greater than 0.5 or CRP greater than 20. In terms of the ANC, there's 2 different values. If you have a procalcitonin, then they have a lower cutoff for your ANC, which is greater than 4,000. But if procalcitonin is not available, then their cutoff for ANC is greater than 5,200. So that would be considered abnormal inflammatory markers. So if you have normal inflammatory markers, you may or may not perform an LP. So there isn't strong recommendations for either or. And again, this was where the art of medicine would apply in terms of shared decision-making, clinician preference, hospital ability, skill set. So if you decided not to perform the LP, so if they have normal inflammatory markers, but no LP was performed, they'd suggest observing in the hospital with or without antibiotics. The comment they wrote in the paper in terms of decision to start antibiotics is that they feel that, again, in this age group of 22 to 28 days, the risk of bacterial meningitis does decrease. So given we've already collected the blood and urine, you could start antibiotics. knowing that you may partially treat a meningitis. But again, they feel that since the risk does decrease in this age group, you could consider treating them empirically. If there is abnormal inflammatory markers, again, there is enough suspicion that there could be at least an invasive bacterial infection or a serious bacterial infection, that in this age group, they would recommend at least admitting them to the hospital. So they would also suggest that it's enough clinical or suspicion rather, that an LP would need to be performed. So if the LP cannot be performed for whatever reason, then they do recommend admitting to hospital and starting antibiotics. If there is a positive CSF or a traumatic CSF, they again recommend observing in hospital and treating with antibiotics. If the CSF is negative, they do have two options. They do suggest that if you decide to send them home in the context of just having an abnormal inflammatory markers, but a normal CSF, they do recommend giving a dose of IV antibiotics before sending them home. Or the option again is to admit them to the hospital with or without antibiotics. The last age group they look at is the 29 to 60 days old. And again, this is where we're getting further and further away from that risk of invasive bacterial infection. So you do the initial partial septic workup of blood, urine, and inflammatory markers. If the inflammatory markers are normal, but you have a positive UA, again, we're thinking more UTI in this case, you'd follow the urine. There's no recommendation for doing the LP. You'd give antibiotics, and then it's safe to send them home. And if everything is normal, again, no LP, no indication to have antibiotics, and they can be safely discharged home. So these kiddos don't necessarily need to be observed in hospital until cultures are negative. Abnormal inflammatory markers, again, in this age group, we're thinking more it could be a serious bacterial infection, which again, the majority of them are a UTI. In this age group, in the context of the inflammatory markers, again, there isn't strong recommendations to perform the LP, but it can be considered. And if it is performed, and that is a positive LP, so again, suggestive of meningitis, it's automatic admission and treatment with antibiotics. If the LP is negative, but again, we have abnormal inflammatory markers and we're wondering if it is more of a UTI, and these kiddos you could either admit or send home with appropriate treatment. However, if no LP is performed, then again, they suggest starting antibiotics, and then you could either admit them or observe them from home. So not one strong indication or recommendation in either way. So this is just my little summary of some of the differences between the CPS and the AAP guidelines. So the first one being the ages that they looked at. So the CPS breaking it into the 0 to 28, 29 to 60, and 61 to 90. Whereas the AAP, again, the major difference being that first week of life is excluded. They break it down a little bit further. So first 21 days of life, they feel is highest risk for invasive bacterial infection compared to the 22 to 28, and then again to the 29 to 60. The comment on whether or not all kids need LP, again, that's the major difference for the CPS guideline, that even in the youngest age group, you don't necessarily need to do LP. You would use your stratification tools, your inflammatory markers to kind of make that decision for the earliest infants. However, in the AAP, under 21 days, they feel is a risk enough for invasive bacterial infection, so all these kids automatically get the LP. Whereas again, in the 22-day plus, you would use those inflammatory markers plus shared decision-making to help to make that decision. Inflammatory markers, CPS, it's included in the stratification tool, so it's highly used in all age groups in the CPS, whereas in the AAP, again, in that under 21 days, it's not necessary, but could be useful later down the course of the hospitalization. Urine and blood is essentially done in all age groups, with the exception in that 61 to 90 days, where you don't necessarily need to do a blood culture, but at the minimum, they would need that UA and culture. And the last thing is just a comment on viral symptoms, which I know can be very tricky to try to decide which kids should be on these pathways. So for the CPS guidelines, generally what they're saying is that there's a non-negligible risk of bacteremia and bacterial meningitis in these kids. So even if there is clinical concerns for bronchiolitis, even if you do have a virus, they suggest still applying the stratification tools to rule out invasive bacterial infections. The AAP guidelines say if there's clinical concerns for bronchiolitis, then they cannot be included in the algorithm. However, they do make a comment that if there's respiratory symptoms, then they could be considered, then you could include them in the algorithm as well.
Okay, and then looking back at our cases and sort of going through the recommendations and investigations that we just were talking about. So just a reminder, baby Jack, he was our 17-day-old term healthy with a sick contact at home with some URTI symptoms and was found to be febrile. So based on the CPS guidelines, you'd go through the algorithm for the infant age 0 to 28 days based on his age. So he was well appearing on your exam. He didn't have any past risk factors. And then you would do your risk stratification tools. And so based on the PCARN rule, he could be high or low, depending on initial investigations. As a reminder, this was one that didn't include age as part of their risk. The step-by-step method, he would be high just solely based on his age. And then the Aronson rule would be high based on his age of less than 21 days, which would get him 1 point plus a fever, which would get him 2 or 4 points, depending on what your temperature was measured in the ED. And then based on that, you would manage whether he was high or low risk based on your initial investigations. You would manage as high or low risk as Kristine outlined for us. With the AAP guidelines, he would be in the 8 to 21 day old group, while appearing, no source of infection, and febrile. So you would obtain your urinalysis, blood culture, and do an LP, plus or minus inflammatory markers. He did not have any increased HSV risk. And so then your next step would be to initiate IV antibiotics and observe him in hospital. And then dependent on that, the results of your cultures, you would either discontinue antibiotics and then send him home after the 24 to 36 hours or treat the infection as appropriate. So for this case, initial investigations were performed. His ANC, CRP, and procalcitonin were all within normal limits. His urinalysis was negative. So as per CPS, he was deemed to be high risk by the step-by-step and Aronson risk stratification tools and low risk by PCARN. With the AAP guidelines, based on his age, he required a full septic workup. So in discussing with parents and making shared decision-making, he did have an LP performed, which was negative. He also had a viral swab sent, particularly in the context of his sick contacts at home, which was later found to be positive for RSV. He had been admitted to the hospital for observation, was started on IV antibiotics, and then were discontinued once the cultures were negative at 36 hours, and he was discharged home with a diagnosis of acute febrile illness related to RSV. And then baby Lucy, she was our 10-day-old term baby who was GBS positive. Mom wasn't sure if she had intrapartum antibiotics, but otherwise was healthy, felt a bit warm, and then was found to be febrile, but otherwise well appearing on exam. So similarly to Jack, Lucy's CPS guidelines would suggest that she was well appearing, didn't have any past risk factors, would have her initial evaluation performed based on her risk stratification, similarly high or low based on the investigations for PCARN, high based on her age from the step-by-step method, and high based on age plus fever with the Aronson rule. And again, you would manage, as Kristine outlined, based on your risk stratification, low or high risk for invasive bacterial infection. And again, similarly to Jack with the AAP guidelines, she also fit into the category of 8 to 21 days. You had your initial evaluation done, including an LP. She was not at increased risk for HSV, and again, would start on IV antibiotics and observe in hospital and then treat as appropriate. So for her case outcomes, initial investigations were performed. Her ANC, CRP, and procalcitonin were all elevated above the reference ranges or the cutoffs that were outlined. Her urinalysis was negative. Based on the CPS guidelines, she was deemed to be high risk by all 3 risk stratification tools. And based on Lucy's age from the AAP guidelines, she required a full septic workup. So as such, she did undergo a full septic workup, including a lumbar puncture. She was admitted to the hospital for observation, was started on IV antibiotics. Her LP was reassuring. Her CSF culture returned negative. Her blood culture was positive, so she remained admitted for her management of bacteremia and consultation with ID on duration of treatment. And the third room, which was baby Max, he was our 37-day-old, so a little bit older than the other 2, born at term. Otherwise well, a little bit fussy, and then was found to have a temperature at home. In the emergency department, he did not have a temperature. His rectal temperature was 37.7, but otherwise well appearing. So he would fall under the infant aged 29 to 60 days with the CPS algorithms. He was well appearing. He did not have any risk factors. Again, you do your initial evaluation and then your risk stratification. So really based on all three, the PCARN, he could have been high or low depending on what the investigation showed, because he was, again, over that age of 22, because he was over the age of 29 days, he no longer automatically fit into the high risk categories. So again, he could be high or low based on investigations. With the Aronson rule, he was not found to be febrile in the ED, so he did not have a point for fever in the ED, which is part of their criteria. And then again, similarly, you'd manage as high or low risk depending on what your investigations and your risk stratifications show. And based on the AAP guidelines, he fit into the 29 to 60-day-old group, was well appearing. He would have a urinalysis, blood culture, and inflammatory markers completed. And then based on that, as Kristine had explained, the two sort of trees in terms of increased inflammatory markers, yes or no, and whether you need to chase an LP or whether you just do a urine and then treat the source if identified. So for Max's outcome, initial investigations were performed. His ANC, CRP, and procalcitonin were all normal. His urinalysis was positive. So based on the CPS, for PCARN, step-by-step, and Aronson, he would have been deemed high risk due to the urinalysis being positive. However, if you remember back to their algorithm, they could go down the low risk for invasive bacterial infection tree if they were low risk, or if the only factor for the risk stratification tools was that the urinalysis was positive. So in this case, as well with the AAP, he had normal labs and a positive urinalysis, so no LP was needed from that perspective. And given that he was deemed to be therefore able to be treated as a low risk for IBI, with the CPS along with parental shared decision making, and when looking at the AAP guidelines, a lumbar puncture was deferred. His urine was sent for culture, was positive. He was started on antibiotics for a suspected UTI, and his blood culture returned negative. So the idea of these cases were to sort of highlight that these are often common complaints that we see in the emergency department, common types of patients that we see in the emergency department, and they have really similar stories and really similar sort of clinical background in terms of being otherwise healthy, being term, which are the sort of requirements to use these tools, but they each had like kind of a tweak in their story, one with being sort of a viral sick contact at home, one being GBS positive and having a bit of a temperature at home, and then one being just kind of fussiness and then found to have a fever. And these had three different outcomes in terms of their diagnosis and their underlying diagnosis and their treatment plans. So Jack, he was diagnosed with a viral illness, Lucy had a bacteremia, and Max had a urinary tract infection. And so kind of going through the algorithms, it is a good exercise to kind of look at different kind of cases and kind of work through what you might do for your investigations and management. And these are all probably cases that you've seen in your emergency department or clinics or that admitted patients. Take-home messages for this presentation: essentially, highest risk for invasive bacterial infections remain highest in infants less than 28 days of life. The majority of infants will have a viral illness. Oh, something happened.
I know, I don't know what happened. Sorry, it just disappeared.
No problem. But essentially, most patients will either have a viral illness or a UTI, but you can't exclude, particularly in these younger aged infants, that a serious bacterial infection, which would be your UTI plus the bacteremia and bacterial meningitis, or an invasive bacterial infection could be also something to think about in your differential as well. And so that is actually the end of our presentation. And we would be keen to take any questions or hear about your experiences in the last couple of minutes here, whether you guys are using which risk stratification tools or what you kind of use in your own practice.
Gina's got her hand up. We'll let her go first. While she's talking, people can fill in the survey.
Good morning. Thanks, everybody, for that great presentation. So we are using the AAP guidelines. I think that one of the core things between the AAP and the CPS guidelines is that further risk stratification that really does divide them into the less than 8 days and then the 21 to 28 days, because they truly do have a different risk of IBI. So I was a bit disappointed that the CPS didn't actually risk stratify them that way. My other comment is that procalcitonin is not reliable in the first week of life. And so it's also a bit disappointing that CPS didn't exclude the less than 8 days of age, at least have some comment about procalcitonin in the first week of life. I don't know if you have any comment about that.
I think the CPS guidelines, because of the risk stratification tools, a lot of them will be deemed high risk based on age alone. So I think that takes part of that question out of the equation, but I agree that that's still an important and valid point.
We have time for one last hand. Batra?
Can you hear me?
We can.
Yeah, I was wondering, using CPS guidelines, febrile young infants, if you have missed any meningitis case. Because I see American AAP guidelines are more sensible to me because they pretty well exclude meningitis by doing earlier LPs. But using CPS guidelines, if any meningitis cases have been missed.
So I will say, by going through the risk stratification tools and looking at patients that were missed from a meningitis perspective in the different cohort studies that they had done, there were patients that I think would be missed by the CPS guidelines, because there were some where all of their inflammatory markers had been low. Really, they would have been classified as low risk, but still did present with meningitis in the end. So I think there's going to be children missed with both, unfortunately. But given that age criteria, so I think we should still really think about age when stratifying these patients and using the different tools. And again, as we've kind of highlighted, definitely the first 8 days, but up until the first 21 days, the risk of invasive bacterial infections remains the greatest.
Yeah, I could probably say that locally here in Ottawa, nobody has been missed because they use the CPS guidelines. Most of these infants, if not all of them, would end up at CHEO because of the testing required. Most of the community hospitals wouldn't be able to do that in like an 8-day-old. And we're not using the CPS guidelines at CHEO. We're using the American Academy of Pediatric guidelines. So as of yet, no one's been missed by those. All right, everybody, we're 2 minutes over, so I don't want to keep people any longer. Everybody, please fill in your evaluation survey. And one quick plug to tell people, staff in particular, that we are in need of staff for the upcoming PEDS residency OSCEs, and you'll be getting an email from Julie Key about that today. All right, thank you, everybody, and thank you to our presenters.